Guinto, who is the Chief Planetary Doctor of PH Lab, a global think and do tank for advancing the health of both people and the planet. Renzo recently finished his Doctor of Public Health degree at Harvard University. We are happy to have you with us today as a keynote speaker. Please, the floor is yours.
Thank you very much. And now I'm trying to share my screen. Can you please provide me the right to do so? Okay, great. Wonderful. Okay. Magandang araw from the Philippines. Good morning, good afternoon, good evening, wherever you are in planet Earth. I am very thrilled and grateful for the kind invitation that the students, the amazing students of Karolinska Institutet has extended to me. I want to start first my presentation by remembering all the affected victims as well as the frontliners that are now fighting COVID-19 across the world. We know we live in unprecedented times, and when we encounter, we humanity encounter these kinds of difficult situation, it also provides us a great moment, an opportunity to really reflect together and find solutions to some of the seemingly unsurmountable problems, such as the ones that we're talking about today. So it's great to be back, albeit virtually. This was my picture a couple of years ago in Karolinska. I wish we can do this face-to-face, because I think these kinds of conversations are best discussed when people are inside the same room, and we can really have a human-to-human interaction, trying to unpack these very difficult concepts and issues. But we're thankful for the gift of technology, online technology, that allows us to have this kind of conversation, a global one. And I believe we have so many participants from around the world that are partaking in this discussion. I was tasked to discuss, and you saw the title a while ago, Decolonizing Global Health for the Post-COVID World. And my task is to give an overview, and I appreciate also Sibyl a while ago who gave already some initial thoughts about this subject, but I'm going to give you a survey of what are the different discourses around this idea of decolonizing global health in this day and age. And I want to start by sharing with you where I'm coming from. It was mentioned a while ago, I'm a physician from the Philippines. And the Philippines is a lower middle income country in Southeast Asia with a long history of colonization. And actually, here in the Philippines, we joke around that we lived for 300 years inside a convent and 50 years in Hollywood. The 300 years pertain to the 3 centuries of Spanish regime and 50 years under American rule. We were also colonized by Japan for 3 years during the Second World War. And we had a 2-year episode as well under Britain. So you can just imagine the layers of colonialism, colonial experiences that my country, my people have undergone for centuries. And we also talked that until today, colonial mentality is creeping in our culture, in our media, entertainment, in our food, etc. You can just imagine how colonialism is very much embedded in our culture, in our street names, in my name even. It's very Spanish sounding, and of course, even in the configuration of our healthcare system. And whenever I think about the relationship between colonialism and medicine, I think in terms of the different directions by which they're related. And one of the connections that I see is, how is colonialism being an agent of medicine? And I want to share with you this very interesting story from Philippine history. It's called the Royal Philanthropic Vaccine Expedition, also called the Balmis Expedition, led by Dr. Francisco Javier de Balmis. It was a 3-year mission from 1803 to 1806. And in this expedition, around 22 orphan boys were used as a reservoir of the newly discovered smallpox vaccine fluid. And these boys were brought from Spain all the way to Latin America and then eventually reaching Manila, Philippines. And this has been described as the first international healthcare expedition in history. It was commissioned by Charles IV, the King of Spain, triggered when his daughter died of smallpox. And I was thinking maybe he's the first Bill Gates, he's the first global health philanthropist. And Edward Jenner, who discovered the smallpox vaccine, even said that I don't imagine the annals of history furnish an example of philanthropy so noble and so extensive as this. And interestingly, there's only one woman in the team, in the expedition team. That's the head of the orphanage. And of course, that sounds very familiar in this current global health regime when global health operations are still very much led by the old boys club of global health. And this expedition is not immune to controversy because the difficulties which children had to pass, of the difficulties that the children had to pass through along, the journey, the expedition. And this is an interesting fact. Names of Spanish and the Mexican boys that were used as reservoir for the smallpox vaccine, their names are recorded. But those of Filipino boys that were sent to China weren't. And that mirrors, global health discovery today. We talk about Ebola, for example, being discovered by Dr. Peter Piot, the head of the London School of Hygiene, but we really never talk about, the doctors in DRC who really, discovered, the disease first and foremost. Nonetheless, this is an example of how colonialism ushered the diffusion of life-saving medicine to the rest of the colonized world, to the colonies, and it shows to you how biopolitics is applied by the state in order to protect health. And again, colonialism as medicine. And then, of course, I also think of this relationship in reverse. How is medicine becoming an agent of colonialism? And we know medicine has a very predominantly paternalistic nature. You can just imagine the power dynamics between physicians and patients. And it's no surprise that medicine can be easily used as an agent of colonization. And the Philippine history, colonial history, has several examples of how this got operationalized, especially during the American regime in the early part of the 20th century. Just a trivia, we were supposed to have been liberated from Spain in 1898. But apparently, Spain sold us to the United States for $20 million. And I don't know how much that is in current exchange rates. And the Americans, apart from using their military might, they also capitalized on the power of medicine and public health to attract the support of what they call little brown Americans. And that's us, that's the Filipinos. And I remember back in history class, back in high school, we were taught that Spain gave us Christianity and America gave us public health and public education. So some of the outstanding scholarship that delve deep into the intertwining of colonialism and medicine in the Philippines during the American period are, these two texts, Colonial Pathologies by Warwick Anderson, which chronicled America's early tropical medicine and hygiene efforts to quote unquote civilize the Filipinos, and Empire of Care by Catherine Sinisa Choi, which traced the origins of Filipino nurse migration back to American colonial nursing education, which was also designed as a space to civilize Filipino women. So again, medicine as colonialism. But of course, it's interesting that in the history of the Philippines, I also saw this narrative of how medicine can also become a decolonizer. And the national hero of the Philippines is actually a physician. His name is Dr. Jose Rizal. He actually I grew up a block away from his house here in the Philippines. And he used the power of the pen to energize the first successful colonial resistance against an oppressor in Asia. And that is, the Philippine revolution against Spain. He would describe colonialism and its effects as the social cancer in his two novels that would spark the Philippine Revolution. So, he was already using, medical metaphors to really describe the situation of the Philippines more than a century ago. He also is very clear about the potential role of medicine in trying to, heal, the colonial disease that is afflicting the country. And it's no surprise to me that he is a colleague and friend of Rudolf Virchow. And, I'm sure the medical students have heard of Virchow's node and Virchow's triad. And Rudolf Virchow is a German physician known as the father of social medicine, who once challenged Otto von Bismarck on a duel. So he's very politically conscious. And he also once said that politics is medicine on a grand scale. So here you see how medicine, physicians in particular, can become agents of decolonization. And so now the question that I'm asking is, how can decolonization, so now I'm thinking in reverse, decolonization or decoloniality can serve as medicine? Or how can decolonization or decoloniality happen in the field of medicine and public health and global health? And, it's interesting, it's important to remember decolonization and decoloniality are two different concepts. Decolonization is the undoing of colonialism, which is a largely political and historical process. And we can say almost all of the countries now have been liberated, at least politically, from the old imperial powers. But decoloniality or decolonialism focuses more on the untangling of knowledge production from a primarily Western or Eurocentric perspective. It is a critique of what is seen as the perceived universality of Western knowledge and the superiority of Western culture. So, another term is, how do you dismantle colonial mentality in these previously colonized nations? So my involvement in Decolonized Global Health started with a hashtag. And this is the exact tweet that I made more than a year ago, November 11, 2018. And if you search it in Twitter, this is the first tweet that used the hashtag Decolonized Global Health. Of course, I am not definitely claiming that I started the movement because, as you can see, it's a response to an earlier tweet there by a colleague. But, over the past year or two, we have seen this, huge surge in interest around this concept, this idea of decolonizing global health. And I would say that maybe this is more of a revival and a reapplication of the decolonial lens, this time in the field of global health. And again, it sounds recent, but it also sounds very familiar. And, some may even describe it as old wine in a new bottle. I remember a while ago, Sibyl already mentioned about the scholarship that already exists trying to look at global health and its activities through a decolonial lens. And here are some of this, this is a sampling of all the articles that have been written recently about decolonizing global health. That the one on top is my contribution. And, my ideas personally have evolved since this article that I wrote last year. And this conversation in blogs, in editorials, have really elicited very important questions. And I think the most, prominent and notable of which is the one by Richard Horton there. He asked in a Lancet commentary, is global health neocolonialist? Or is it really, inherently colonial? And if it is, then can it really be decolonized? These are great questions to ask that will require vigorous and inclusive discussions in order to translate into concrete and lasting change. And that's why I'm happy that we're having this conference. And here you will see, the different schools of global and students of global health that have been energized by this concept of decolonizing global health. DevX featured some of us last year, and we were described there as the activists trying to decolonize global health. But one thing is very obvious in this listing of universities, which includes my alma mater, Harvard, but also includes Karolinska, that is hosting this conference. All these student groups and conferences are held in American and European universities, all in the global north, all colonial powers, old colonial powers. And I think the next arena for this conversation is the global south, countries, developing countries that are still suffering from, the colonial legacies of their former colonizers. Now I want to link this conversation of decolonizing global health with COVID-19. I will be remiss not to make this connection. And while this decolonizing global health discussion is evolving, COVID-19 suddenly shows at our doorstep. And there are many metaphors that have been attached to COVID-19, particularly war or military metaphors. Again, a manifestation of colonial health's or global health's colonial mentality, that obsession with empire. But I prefer to use two other metaphors. And, one is that COVID-19 is really a mirror and a magnifying glass that basically reminds us of what is already abnormal in global health. And, there's really no such thing as new normal to create to begin with. The globe, for example, and you will see a sampling of the articles there, the Global Health Security Index developed by Johns Hopkins seem to have misrated a lot of the Asian and developing countries that have done so well so far in the COVID-19 response. And those that were ranked highly, with US at the top, failed to meet the index's expectations. It reflects the underlying assumptions that we make in the way we measure things in global health. We've also heard of French doctors suggesting to use Africans as guinea pigs for the new vaccine. Lockdowns that were imposed in high-income countries are now being recommended to low-income countries in Africa, where the basics such as food, water, and space are not even within reach by people. And media coverage of the pandemic has sought mostly not just male, but also Western voices talking about miracles in Asia and the upcoming crisis in Africa. And COVID-19 just provided a new stage as well for the continuous battle of old empires like the United States and new ones such as China. So again, this is how COVID-19 is merely a reflection of the issues that already confront global health today. But also the other metaphor that I want to use is that COVID-19 is serving as a gateway, a portal to the next, hopefully towards a much better and decolonized world. I've seen webinars with all Asian panels organized by Western organizations and universities who are seeking for lessons to be learned, to be copied from from countries that are previously and patronizingly described as quote unquote the Orient. Several commentaries have already pointed out how COVID-19 is a humbling experience and a slap on the face of Western-centric global health, as we witness the early success of some Asian countries and the crisis faced by healthcare systems in Europe and the US, unfortunately. And the colonizing proposals, both old and new, have began to float, such as the idea of moving the WHO headquarters to sub-Saharan Africa to ensure that it's closer to places where its expertise is needed the most. And as the West grapples with own domestic health crisis, places like Africa can use this opportunity to decolonize and liberate itself from Western imposition and dependence, as suggested by the article at the bottom. So, that is the context where we live in and in which we are having this discussion around decolonizing global health. But one thing is also interesting, there is no single definition. And right now there are many interpretations, which I will talk about later, but let me share my perspective. I think that, we know that in the field of global health, equity is our fundamental value. It's our core tenet. But we only apply equity, greatly in the arena of health outcomes. So, we talk about equity in maternal health, equity in healthcare access, in NCDs, etc. But of course, unfortunately, we are still far from achieving health equity for all worldwide. And COVID-19 is expected to exacerbate existing inequities. But equity has not been really applied, intentionally and explicitly to the realm of global health operations, how we hire, how we conduct research, how we make decisions, how we fund, how we set priorities. And for me, decolonizing global health is the application of equity, not just in the outcomes of global health, but also in the operations of the global health apparatus. For me, and that's my second bullet there, the decolonizing process in global health, like the colonialism at large, is both personal and psychological, as well as societal and structural. And later we'll be touching on a lot of the ways by which decolonizing global health manifests. And really, ultimately, it's about tackling the unequal distribution of power. Who wields power to make decisions and to fund and to write the papers. And unfortunately, it's still the old white senior boys club of global health deciding for the rest. Now, I earlier mentioned that there isn't a single definition and that there are, many different interpretations. And maybe that's the beauty of decolonizing global health. Maybe we do not really need a single or a consensus definition, because there's beauty in allowing different flowers, to bloom, and for the different threads to be interwoven into an evolving decolonizing narrative. And the first thread that perhaps has been visible recently is the call for greater racial diversity and inclusion in global health activities, in hiring procedures, in career progression, in discrimination in the workplace. And for instance, I want to share with you this article written by my friend Ngozi Arundu, who, and this article depicts her personal experience of racial discrimination in both classroom as a teacher and in the field as a researcher, despite her impressive qualifications and awesome competence. She is a graduate of the London School of Hygiene. And then, of course, not only in the workplace do various forms of discrimination and exclusion along racial, ethnic, gender, and socioeconomic lines manifest, but also in both the conduct and publication of research, the composition of advisory or editorial boards, and even in conference panels, as you can see in the picture. Recently, there were papers that investigated lack of diversity in authorship. So, for example, there's one article there talking about African researchers being stuck in the middle because they're neither the lead authors nor the senior authors at the end of the byline. I'm sure we still see a lot of these, Manels or all-male panels. But I want to add, to the vocabulary, we also see a lot of HICANELs, high-income country panels, or WANELs, white panels, discussing the future of global health, guess where? In Africa. So, these panels, need to go, and we need, more diverse panels discussing the future of global health, globally, and not just in one part of the world. And when it comes to editorial boards in journals, there's still very little representation, both at the level of editor-in-chief, but also, as a member of the editorial board. I saw one recently launched Global Health Journal, which I will not name, with only one representative from a low and middle income country. Our challenge is not just how to increase representation and diversity, but also how to move from mere tokenism, mere decoration, to true and respectful engagement. Another related thread is, this, area around increasing reciprocity in global health, or the lack of reciprocity in global health. And it's mainly about how opportunities in global health are mainly unidirectional. For instance, students from the global north being able to participate in global health projects and immersions overseas, while those from the global south cannot even, apply for a Master of Public Health program in Western countries because the requirements are just so prohibitive. And in addition, as we have seen more anti-migration and supranationalist sentiment in recent years, global health conferences, and we know most of them happen in high-income countries, have become much more inaccessible, not just because travel is expensive, but also because scholars and students are being denied of visas. And you can see some of the articles that were published in the past year or two about this. And to think that researchers from the global north possess passports that allow them to travel anywhere and conduct the research and attend the conferences that they want. And so there is really a need for more reciprocity and bidirectional arrangements in global health education, conferences, and other activities. As earlier mentioned, global health as a concept is deemed inherently colonial, having been developed by universities and other institutions in old colonial powers, and carrying with it Western notions of what a healthy society is, how should the world work, how should health systems operate. So these are the values and frameworks of global health. And language, as we know, the vocabulary, the lexicon that we use is a visible manifestation of these values and frameworks, and they should be constantly interrogated as well. You may have noticed my hesitation earlier in using the terms global north or global south. And some ask, if it's time to get rid of these terms that resulted from the branded line, as you can see in that map, which is a product of a 1960s commission headed by former German Chancellor Willy Brandt that split the world into two, not just in geographic terms, but also in social, economic, and cultural hemispheres. On the other hand, maybe we should keep on using these terms and keep on reminding ourselves of the gross inequality that still exists between North and South, because stopping their usage is a form of denial that such gaps still remain until today. And then, apart from values, frameworks, and language, modern day health systems in many former colonies around the world are carrying with them colonial baggages or legacies that perhaps perpetuate chronic health problems that they face, even being transferred, across generations. So for example, health services may have been designed by former colonizers to address the needs of privileged groups, and healthcare disparities that affect marginalized populations were carried on even post-liberation. And as I earlier mentioned, the outbound migration of Filipino health workers, the nurses, it's not a recent phenomenon, but it can be traced back to American colonialism that commodified the nursing profession as a civilizing opportunity, but also as a potential export for the country. So colonialism may have set the stage for path dependency and institutional inertia that prevent post-colonial societies from undertaking essential and massive healthcare reforms, such as achieving universal health coverage and now addressing a pandemic. And then while the colonial remnants are still there, within countries, there are also new forms of colonialism or neocolonialism that continue to shape global health priorities, funding, and operations. The list of neocolonizers is long and diverse. So, for example, you can see here old powers like the US and Europe, new powers like China that is building its Belt and Road Initiative, and the BRICS countries as well, multilateral agencies such as the World Bank and IMF, bilateral aid agencies like USAID or Sweden's SIDA, transnational corporations like pharma companies, or even those that sell unhealthy products like big tobacco or big soda, philanthropy such as Gates Foundation, Rockefeller Foundation, the Wellcome Trust, consulting firms like McKinsey and BCG, universities like Harvard or Hopkins or London School or even Karolinska. And there's a great amount of literature investigating the undue influence of these actors in the political economy of global health. And then another thread as a countervailing force to neocolonizers is, how do we create spaces to amplify the voices of those unheard, or those tokenistically listened to for a long time, and how these underrepresented groups can claim space and expand their space. And in the past decade, we have seen the emergence of fellowships, many of them still developed and funded by the global north, and to build the capacity of next generation scholars and practitioners to become effective and credible participants in the global health discourse. There are also discussions about the rise of global health think tanks in low and middle income countries to provide rigorous analysis and powerful solutions that are complementary or even alternative to the ones forwarded by high-income universities or think tanks, such as, for example, the Graduate Institute in Geneva or Chatham House in London. This calls for radical rethinking in capacity building that builds not mere mouthpieces of Western-centric knowledge, but as originators of new, alternative, world-changing ideas. And then ultimately linked to the issues around representation, reciprocal arrangements, and changing mindsets and frameworks. Decolonizing global health is also about how we can manifest humility and respect in global health. And I am reminded of this book by Sir Nigel Chris, the former head of the UK's National Health Service. It's entitled Turning the World Upside Down. How can the North learn from the South? And how can the West learn from the East? And I think COVID-19, as I earlier described, is a humbling experience for all of us, but especially for our Northern colleagues, as we witness early successes in places that we always assumed to be inferior because, based on mindsets and metrics. And respect in global health also means dismantling all forms of colonial activities, such as volunteerism of Northern students to make their CVs look good and make them more employable or acceptable to med school. Or global health consulting by experts, quote-unquote experts, who have no experience in developing countries, or parachute research and fishing expeditions by Western researchers to add to their publication portfolio. In fact, I have encountered experts, quote-unquote, who claim that they've worked in country X or country Y, but all they've done is really to analyze a data set from these countries and really never have been to these places. So these are the things that need to change. And here, maybe this is in a way a summary of the ideas that I shared with you a while ago. This is my tentative framework synthesizing all the points I talked about a while ago. Definitely not exhaustive, but it's a synthesis of the various disciplines and different analytical lenses, interested in all aspects of global health operations, with a rough idea of how a decolonized global health would look like, which in turn will bring equity, fairness, and justice in the realm of global health outcomes. So now I'm moving to the last part of my presentation. I want to also give some words of caution. And decolonizing global health is a difficult and it's a sensitive struggle. And I think the first word of caution, and this applies to me personally, is that in the process of decolonizing, we must ensure that we don't end up becoming neocolonizers ourselves. It just shows, the delicateness, the sensitivity of the struggle. And therefore, there is really a need for us to be reflexive all the time, which Sibyl already mentioned a while ago. After all, each of us is an interplay of privilege and disadvantage and of personal and societal history. So for instance, I'm very cognizant of my own positionality. I may be Filipino, I'm Asian, with brown skin, aspiring to make a difference in my home country. That is why I'm back here in the Philippines. But also, in this process of decolonizing, I need to also acknowledge my own privilege. I am not, part not just of my countries, but also of the world's highly educated elite, having received my education from a prestigious university, which was also an agent of colonialism before and even until today. And I'm bringing Western ideas and frameworks, and with a hope to combine them, with local knowledge and to attempt to solve domestic issues. So the colonizers at the end of the day are complex individuals with diverse experiences, qualities, and histories. There's also a need for moral courage, and that's the one in the middle. In our young careers, we will always be confronted with plenty of dilemmas. One is advancing, our personal and our professional interests versus achieving higher societal goals, such as structural decolonization. One friend was actually asking me, aren't you afraid that you might not be very hireable, by the likes of WHO because they think you're so radical? And I think, organizations, if they want to really decolonize, they should be open to new alternative voices, to the ones with the moral courage to question and to challenge the status quo. Some may opt to be diplomatic, to ensure that, different stakeholders are engaged in a conversation. Others may choose to be bold and daring, and they may be perceived as too disruptive. And as I've said, they might not be invited to get a seat around the table. So it's moral courage, not reckless courage, that we need to develop as decolonizers so that we remain consistent with our mission without diluting the message. And finally, there's a need for a deep sense of mission. I already used the word mission, knowing and internalizing your why to find out the what and the how. And I always see global health not as a career. I really hate that word, but as a mission, as I've already used several times. And I think if that is your outlook, then it's not anymore just about finding the next job or creating a new opportunity for yourself, but more so it becomes an obligation to ensure that you are not the last one benefiting from the opportunities. I feel very blessed and privileged that at a young age, I had the chance to witness global health and its colonial manifestations firsthand. And even speaking about decolonizing it and being connected with fellow decolonizers, they themselves are a form of privilege. And with power comes responsibility, with opportunity comes obligation. And, this is interesting. Yesterday, Laura Macumba, who is one of the organizers of the Colonized Global Health movement in Duke University, published this article lamenting about the movement being stuck in American and European universities and not happening in the global South, where colonial oppression and silencing remains. And, woke students, from the global North have nothing to lose. They'll still get the jobs anyway, because they demonstrated their wokeness in their CVs. They've organized Decolonizing Global Health. But unfortunately, those from the South will not even dare speak, as they can be sent to jail. And so, reflexivity and moral courage and sense of mission are definitely critical in making sure we truly decolonize and we just don't, as mentioned by Laura, prove our wokeness. The colonial theories as well are already existing in other fields outside of global health. And that's why, another word of caution, don't forget
Thank you.
The Colonial project. It's great that we have Siseko and others who will share more ideas later. And, we need not reinvent the wheel, but really enrich the discourse through cross-pollination. So another word of caution, let's not, let's question ourselves. Are we indigenizing? Are we, inviting to nativism? And, is it just obsession or fascination for the exotic? I'm reminded of this work by Edward Said, which is about Orientalism, this condescending, patronizing view of the East as backward and uncivilized. So we need to be careful that we don't, commit these kinds of thinking. And there's really a delicate balance that needs to happen. Okay, I'm moving towards the end of my presentation. another word of caution, let's go beyond the cosmetic. Let's apply the iceberg model. Adding more people of color in an advisory board, or having more African sounding names in the research byline. They're an important first step, but really it's all about the mental models that shape global health thinking and operations. And then, I just want to insert planetary health and recognize its decolonizing potential. I've been a very devoted advocate of planetary health, this integrated vision for the health, not just of people, but of the planet as well. And really, planetary health is the answer to colonialism of humanity over nature. And it's an invitation to go from an ecological standpoint, it's all about humans over the rest, and shift towards ecological. Which means multi-species consciousness, recognizing our oneness with nature. So to close this presentation, I just have a few more, challenges. First, to Karolinska. And, I'm not here to give a playbook or a cookbook on what Karolinska should be doing. And this conference should be the start of a longer process. It cannot just be a one-time event. And this, you should examine your education, research, and outreach work through a decolonial lens. Examine the colonial legacy of Sweden towards other countries, whether it's actual colonization or not, as well as towards its own people, your indigenous populations, for instance. And examine Karolinska and Sweden's neocolonial influence in global health. We know Sweden is a very important player in global health funding and priority setting. And then what can we do, all of us? And, I've talked already about routine self-reflection, about building, global alliances, not just with friends from the global south, but also allies from the global north. As they say, it takes two to tango, and critical allyship is very, very critical. Claiming our space, speaking our own voice. We can't wait for others to speak on our behalf. Let's build a culture of mentorship, find a mentor and be a mentor. Critical global health education, we need to, take what we learn inside the classroom and read from books, not just with a grain, but with a pound of salt. Listen to alternative voices. And, it's easy to be cognitively biased to, only hear or read what, a Harvard rockstar professor is saying, or what the Geneva pundits are talking about. But there are new voices across the world that we need to amplify and listen to their voices. And finally, we need to tackle the systematic roots of global health's colonial features. It will not happen overnight, so hang in there. And so what really gives me hope, these are, phases of a lot of the emerging scholars and practitioners and professionals from around the world starting to decolonize global health. I dedicate my presentation to the Emerging Voices for Global Health Fellowship program organized by the Institute of Tropical Medicine in Antwerp, which for nearly a decade has really provided opportunities for new voices to emerge in global health. And let's build the enduring alliances, expand our growing tribe, and spread the positive virus of decolonizing global health in preparation for our post-COVID future. Thank you very much, and I look forward to an energetic conversation with you today. Thank you.
Thank you so much, Renzo. Indeed, the topic and the issue are not as simple as people think, and medicine as well as public global health do play an intertwining role of being a tool of colonization, but also a tool of decolonization. Thank you so much.